Bismillahir Rahmanir Rahim. Our subject today about interpretation of liver function tests. This is a very important topic for every physician. Whatever your subspecialty in the future, internist, surgeon, gynecologist, ophthalmologist, you should know at least basic knowledge about how to read liver function tests of any patient. To start with, we should know first of all what are the liver functions to be able to assess. Actually, the liver carries out a lot of functions, from purification, transformation, and the clearance of toxins, drugs, hormones, etc., metabolism of carbohydrates, fats, amino acids, regulation of glucose and cholesterol, storage of glucose, fat-soluble vitamins, folic acid, vitamin B12, copper, and iron. In addition, the liver synthesizes and secretes clotting factors, transporter proteins, cholesterol, bile for digestion, glucose, etc. So, the liver does too much for any single test or set of tests to determine. Actually, liver function tests are groups of laboratory blood assays designed to give information about the state of patient's liver. The parameters measured include prothrombin time, INR, serum albumin, serum bilirubin, whether direct and indirect, and liver enzymes, SGPT, SGOT, now called ALT and AST, alkaline phosphatase, and gamma GT. Some tests are associated with functionality, like prothrombin time, albumin, and bilirubin. Some with cellular integrity, like transaminases, and some with conditions linked to the biliary tract, like gamma glutamyl transferase and alkaline phosphatase. Although it seems to be a misleading term, liver function tests, because not all the functions can assess the liver function. However, it is firmly inserted in the medical vocabulary and in the medical literature. So, the American Association for the Study of Liver Disease has changed the name from liver function tests to liver biochemistry test, however, still used in textbooks. Liver function tests can be used clinically to detect the presence of liver disease, to distinguish among different types of liver disorders, to gauge the extent of known liver damage, and follow response to treatment. Some or all of these measurements are also carried out on those individuals taking certain medications like anticonvulsants are a notable example, in order to ensure that the medications are not damaging the person's liver. And now, let me introduce you your tools. As a professional, you should know the tools you will use to assess the liver functions, limitations of these tools, advantage of each one. Liver function tests, or according to the new nomenclature, liver biochemistries include liver enzymes, alkaline AST and ALT. These are called tests of liver integrity. denotes liver injury. Alkaline phosphatase, bilirubin, and gamma GT and 5-nucleotidase are tests of biliary tract integrity, cholestasis. And lastly, but by no means the least, tests of real liver cell function. Serum albumin, which is synthesized by the liver, serum prothrombin time and INR as coagulation factor are produced by the liver, and serum bilirubin as another denominator of real liver function. The first group, tests of liver cell integrity or injury. These are the transaminases. It include alanine aminotransferase and aspartate aminotransferase. The old names for alanine aminotransferase, GPT, for aspartate aminotransferase, GOT. And now, what are transaminases? Transaminases are enzymes that catalyze the transfer of alpha amino groups from amino acids to alpha keto acids. These enzymes are important in gluconeogenesis. That's why they are called aminotransferases. Comparing the two well-known liver enzymes or transaminases, AST and ALT. AST is found in the cytosol and in the mitochondria. Both cellular cytoplasm, the cytosol, and mitochondria contain AST, widely distributed throughout the body, in the liver, not only the liver, but also in cardiac muscle, skeletal muscle, kidneys, brain, pancreas, lung, leukocytes, and erythrocytes. On the other hand, the ALT or GPT is only cytosolic in the cytoplasm and mainly in the liver cell. It exists mainly in the liver, but exists in low concentrations in the kidney, heart, and skeletal muscles. That's why it is more specific indicator of liver injury than AST. And now, how did these enzymes rise in the circulation? When there is injury to the intact hepatocyte and the cell wall membrane has been injured, the intracellular enzymes ALT and AST will leak directly from the injured cells through the fenestrated endothelium into the lumen of the liver sinusoids and to the circulation. That's why they will raise with any injurious agents that injure the liver cell. If the injury include the mitochondria also, the AST will be more increased. So, blood level roughly proportional to the number of hepatocytes that died recently within hours or days. Month-to-month variation is expected. Minor changes in levels have no prognostic significance. It is worth to note that direct release of enzymes into blood through fenestrated endothelium allows rapid quantitative assessment of ongoing hepatocyte necrosis. So, increases in serum aminotransferase levels reflect damage to tissues rich in these enzymes, and the changes in cell membrane permeability to allow AST-ALT to leak into the serum. Degree of elevation, however, does not correlate with the extent of liver injury. AST half-life is shorter than ALT half-life. That's why ALT remains elevated for longer time during recovery from liver disease or acute liver insult. So, a very important take-home message that the magnitude of elevation does not necessarily correlate with extent of liver function or dysfunction at the present time or in the future. To understand, you should note that AST and ALT intracellular enzymes, when raised in circulation, denotes the rate of destruction of hepatocytes, Meanwhile, liver function depends on the number of functional hepatocytes left intact in the liver. And now to another group of liver biochemistry tests, which is tests of biliary tract integrity or tests of cholestasis. The main prototype of this group is the alkaline phosphatase. Alkaline phosphatase enzyme is present in nearly all tissues, but with different isoenzymes, hepatic isoenzyme, bone isoenzyme, and so on. But unfortunately, most of the labs produce total alkaline phosphatase without determining the isoenzyme. It is localized in the microvilli of the bile canaliculus in the liver, also present in bone, intestine, placenta, kidney, and white blood cells. Elevation may be physiologic or pathologic. In association with the microvilli of the bile canaliculi, also there is another enzyme which is the 5-nucleotidase. It has a spectrum of abnormality similar to that of serum alkaline phosphatase, but more specific to hepatobiliary disease because it is mainly in the liver, not in extrahepatic tissues. May be used to confirm hepatic origin of elevated serum alkaline phosphatase. As we said, alkaline phosphatase has different origins. So if you find alkaline phosphatase increase, with increase also 5-nucleotidase, this means that this alkaline phosphatase came from hepatic origin. But if alkaline phosphatase, there is dissociation with increased alkaline phosphatase, not accompanied by increase in 5-nucleotidase, this is highly suggestive that this alkaline phosphatase is of extrahepatic origin. Gamma-glutamyl transpeptidase is another membrane-bound enzyme that catalyzes transfer of gamma-glutamyl groups of peptides as glutathione to other amino acids. Abnormal values for gamma-GT are seen in same spectrum of disease as alkaline phosphatase and 5-nucleotidase. Gamma-GT levels are increased in cholestasis and hepatocellular disease, both of them. It is not elevated in bone disease, so can help to detect the origin of alkaline phosphatase. Elevated gamma-GT has low specificity for liver disease. Extensive evaluation of isolated elevated gamma-GT in otherwise asymptomatic patient is not usually indicated if there is isolated increase. And now to the real liver function tests. Tests really denote the liver cell function. As you all know, the liver cell is the main source or is the source of serum albumin. It synthesizes the serum albumin. So assessment of serum albumin level is a good indicator of liver function. Also, the liver cells produce the clotting factors. So assessment of prothrombin time or INR is another important denominator of liver synthetic function. Bilirubin also, but the liver cells has 3 jobs to do with bilirubin. Usually the liver cell uptake or eliminate the indirect bilirubin from the circulation, so elimination is the first function. Then it conjugate the insoluble bilirubin to form conjugated bilirubin, the water-soluble form. So the second function is conjugation. And lastly, excrete this conjugated water-soluble bilirubin into the biliary tree to be excreted through bile. So the bilirubin level is affected by the liver function. The liver cell has 3 rules during the cycle of bilirubin: bilirubin elimination from the circulation, conjugation inside the liver cell to convert water-insoluble bilirubin into water-soluble bilirubin, and lastly, excretion of the conjugated bilirubin from the liver cell into the biliary tree. If the liver is markedly diseased, the reserve function will be lost. It is worth to note that albumin monitors slow changes in liver function because its half-life is somewhat prolonged, reflects long-term liver dysfunction. The prothrombin time, on the other hand, monitors rapid changes in liver function, hours to days, maximally weeks, because it reflects either short or long-term liver dysfunction because of very short half-life. Other clues to globally impaired liver function: bilirubin itself, as we mentioned, it goes up with any disease that globally impairs liver function, of course, or blocks bile flow. This is in cholestasis. But when there is deterioration liver function, usually bilirubin goes up. Hypoglycemia is a late finding, indicates very poor liver function. Blood urea nitrogen, low blood urea nitrogen is a late and poorly specific finding in liver dysfunction due to poor urea synthesis. Ammonia will increase, causing encephalopathy, and poor synthesis of blood urea nitrogen. But these other clues can also reflect the functional status of the liver. Before going to interpretation of liver function tests, I think now we can recognize the limitations of our tools, which include lack of sensitivity. These liver function tests may be normal in cirrhosis or even a patient with hepatocellular carcinoma, which denote grave situation of the liver. Also, lack of specificity. Aminotransferase levels may be elevated in musculoskeletal or cardiac disease. The other point is that degree of elevation does not always correlate with liver functional status. As we mentioned before, the raised enzymes can express the extent or the amount of injured or dead liver cells, but the function depends on the amount of the remaining liver cells, functioning liver cells. A group of tests is needed in order to infer functional liver status. Probability of liver disease is high when more than one test is abnormal or the findings are persistently abnormal on serial testing. Another pitfall is that in real life, the situation is not that clear, black and white. Actually, mixed injury and obstruction patterns are common in real life. A normal does not mean normal. Do not assume that a normal test result indicates absence of liver disease. As we mentioned before, even in HCC and cirrhosis, which is the end of the story of most of chronic liver diseases, you may find the liver enzymes almost normal. And now can you tell me, every one of you, what did you see in this photo on the left side of the slide? Okay. Some will say this is a bridge. I hear others that they can say this is a face of somebody. So although the photo is one, our interpretation was different. So the message is liver function test is not simple reading. It should be read within the frame of the whole story of the patient, not in isolation. Considering this concept that liver function tests should be read within the whole story, you cannot read in isolation from the symptoms, signs, and other investigation. Let us go to our featured presentation. In the coming minutes, we will start to explain a roadmap for interpretation of liver function tests. And now, after we have discussed in the previous slides the limitations and the power of our tools, the advantage and disadvantage of our tools, let us use these tools to assess the liver function through these coming 6 steps. To read any liver function of any patient, you should go through this roadmap. First step, think of non-hepatic causes. Second, look at pattern of abnormality. We are dealing with cholestatic liver injury or liver disease, or hepatocellular liver injury or liver disease. After that, look at tests of functionality. Does this liver insult affect the liver function or not? This is a very vital question. Then after you answer these 3 questions, you will be able to classify the abnormality, whether we are dealing with hepatocellular or biliary abnormality. Is it massive hepatocellular injury? Is this liver is a failing liver or just a diseased liver? The 4th step is to consider the differential diagnosis of each category. Put in differential diagnosis the most common and the most treatable. The last step is to perform the diagnosis. And don't forget, the diagnosis will depend on history, examination, and investigation. You cannot isolate the biochemical tests and read it away from the patient, otherwise you will have blurring in your opinion. First step, think of non-hepatic causes. As we mentioned before, there are extrahepatic sources of most of the liver enzymes. So before considering the patient is a hepatic patient, exclude carefully extrahepatic causes. For example, elevated bilirubin may result from red blood cell hemolysis destruction, like hemolysis or intra-abdominal bleeding or hematomas. Elevated ACT may be from muscle injury or even cardiac muscle injury, like acute myocardial infarction. Alkaline phosphatase may be of bone origin, placenta, kidney, or intestines. Gamma GT, the source may be from the heart or red blood cells, and so on. The second step is to look to the pattern of abnormality. Are we dealing with cholestatic liver disease or hepatocellular disease? Actually, most of the parameters of liver biochemistry will increase in any liver disease, but we will look to the main change. If the main change in the enzymes denoting liver injury, marked increase in ALT and AST, rather than the other groups, which are a group of biliary integrity or cholestasis, alkaline phosphatase and gamma GT, and functionality. So, if the main change in the liver enzymes denoting liver cell injury or integrity, by which we mean ALT and AST, this means we are dealing with hepatocellular disease. On the other hand, if the main increase in the parameters denoting biliary tree integrity, which is marked increase in alkaline phosphatase and gamma GT with minimal change in ALT and AST, this means we are dealing with cholestatic disease. Just let me give one question. Where is bilirubin? I can put bilirubin in any site. I can put it in the cholestatic group, it will be okay. And I can put it in the hepatic group, it will be also okay. So this is very important. If you see the row in the bottom of this table, bilirubin may be within normal or 1 or 2 plus in hepatocellular injury. The same issue in cholestatic injury. The same issue in mixed liver disease. Only in isolated hyperbilirubinemia it is usually increased. This is very important to avoid one of the common pitfalls of even the clinicians. They consider bilirubin as a denominator of cholestasis. Meanwhile, no, bilirubin has two faces. It can be a denominator of cholestasis, and it can also be a feature of liver cell injury. So, as we mentioned, many clinicians mistakenly interpret elevations of direct reacting bilirubin to indicate that cholestatic liver disease is present. It is apparent that the serum bilirubin level plays no useful role in categorizing a case as hepatocellular, cholestatic, or infiltrative. The bilirubin level may be normal or elevated in each type of disorder. Viral hepatitis A prototypic hepatocellular disease, may frequently be associated with bilirubin levels that are high, whereas primary biliary cirrhosis, a prototypic cholestatic disorder, is associated with normal serum bilirubin level except in later stage of the disease. So, a very important take-home message is serum bilirubin levels should be disregarded when trying to decide whether the liver test pattern is more suggestive of hepatocellular or cholestatic disease. The AST to ALT ratio is another important pattern to recognize the pattern of change in liver biochemistry. The commonest pattern in most of hepatocellular diseases increase in ALT rather than AST. This is typical for most liver conditions, including chronic viral hepatitis and NAFLD. But if the rise in AST is exceeding the rise in ALT, this is usually suggestive of alcoholic liver disease, because ALT is more strongly inhibited by vitamin B6 deficiency, common in alcoholics. Also, alcohol causes mitochondrial damage, releasing more AST, because as we mentioned before, AST is both cytosolic and intramitochondrial, while ALT is cytosolic only. So, after we look to the pattern of abnormality, if we are dealing with cholestatic liver disease versus hepatocellular disease, the second step, we are dealing with hepatocellular disease. Look to the relation between AST and ALT. Most of liver diseases will cause rising in ALT more than rising in AST, especially viral hepatitis. If the rise in AST is more than the rise in ALT, this is usually denoting alcoholic liver disease, especially if the peak of AST is less than 300. But if AST exceeds 300, look for another cause than alcoholic liver disease. And now to the third step in our roadmap. Look at tests of function to decide if you are dealing with simple liver disease or failing liver. The main parameters, as we mentioned, that indicate the functional status of the liver, we have serum albumin level. Although serum albumin has several drawbacks, that it depends, or several limitations. First, it depends on nutrition. Can be influenced by hormonal factors, catabolism, can be loss in stool and urine, protein losing enteropathies or proteinuria. So, low serum albumin is not specific for liver disease. So other causes should be ruled out before attributing the low albumin to liver disease. That's why. The other thing is it has a long half-life, so measurement of serum albumin is useful in chronic liver disease and is a component of grading systems. Obviously, non-hepatic causes of hypoalbuminemia need to be excluded, like proteinuria and malnutrition. Because it has a long half-life from 3 to 4 weeks, it is not therefore a good indicator of liver dysfunction in acute hepatic injury. On the other hand, the prothrombin time or the INR, when I say prothrombin time or INR, the meaning, it is the same meaning, because the INR is another logarithmic way to express the thrombin time. So we are talking about the same thing. In presence of adequate vitamin K, the liver synthesizes coagulation factors except factor 8. Clotting abnormality indicates impairment in ability of liver to synthesize the clotting factors. Provided the vitamin K is not deficient, the body has its enough vitamin K. So, prothrombin time is a useful indicator of liver failure in both acute and chronic hepatic injury, provided that cholestasis with malabsorption of vitamin K has been excluded by parenteral administration of vitamin K 10 mg per day for 3 days. In vitamin K deficiency, vitamin K 10 mg sub-Q decreases prolonged prothrombin time more than 30% within 24 hours. So, in acute diseases, acute liver failure, the prothrombin time may rise to over 50 seconds, and it is the most important predictor of outcome. In cirrhosis and chronic liver disease, levels are usually 2 to 5 seconds prolonged. A prothrombin time elevated to over 20 seconds in a cirrhotic is an indication of very poor synthetic function and is associated with a poor outcome. This slide shows the modified Child-Treugut-Bug score for grading severity of liver disease. This is one of the famous and the commonly used all over the world scores or grading system to express the severity of liver disease. Just I would like you to note that we are using in this grading system 3 laboratory parameters and 2 clinical parameters. The 2 clinical, ascites and encephalopathy. And the 3 laboratory parameters include number 1, the serum bilirubin, then serum albumin, then prothrombin time or INR. So don't forget the bilirubin is the first marker to assess the liver functional status. So it is not a denominator of cholestasis. It can play here and can play here. So it has no much role to differentiate whether we are dealing with cholestatic liver disease or hepatocellular liver disease. According to this grading system, we will give a score to every patient according to his serum bilirubin, serum albumin, serum INR, and if there is ascites or encephalopathy or not. If bilirubin less than 2, you will take score 1. If from 2 to 3, 2, more than 3, 3, and so on, by the end of the day, the score will be calculated if the total summation of the score between 5 to 6 will be called grade A. If between 7 to 9, it is grade B. If from 10 to 15, this is grade C or child C, which is the advanced liver cell failure. So, as we mentioned, first step to read or to interpret liver functions is to exclude extrahepatic abnormality. Second step, look to the pattern of abnormality, cholestatic versus hepatocellular injury. Third step, look to the functional status of the liver, compensated or decompensated. The fourth step, according to the previous three steps, classify the abnormality, whether we are dealing with primarily hepatocellular or biliary injury, according to the main change in liver biochemistry. If the main rise in transaminases, this is hepatocellular injury. If the main rise in alkaline phosphatase gamma GT and bilirubin, this is mainly cholestatic liver disease. But don't forget, bilirubin can be put in both arms. It has no much differentiation. Is there massive hepatocellular injury if liver enzymes exceed 1000? Is there evidence of functional abnormality according to the clinical features of failing liver or the INR, albumin, and bilirubin? And now to the fifth step, considering the differential diagnosis for each category. If we identify that we are dealing with hepatocellular damage, put differential diagnosis. Or with cholestatic liver disease, go for differential diagnosis. And the main principle we know, diagnose the common and treat the curable. So differential diagnosis should consider the more prevalent causes. In a trial, to limit the differential diagnosis, we can put the differential diagnosis taking in consideration the degree in elevation of transaminases. If there is mild elevation in ALT and AST, and by mild elevation we mean that elevation less than 5 times the normal, if the dominant is ALT, we should put in differential diagnosis chronic hepatitis C, chronic hepatitis B, acute viral hepatitis from A to E, steatosis, steatohepatitis, hemochromatosis, medications, autoimmune hepatitis, alpha-1 antitrypsin deficiency, Wilson disease, and celiac disease. If the main increase in AST is predominant, we will put alcohol-related liver disease, steatosis, steatohepatitis, and cirrhosis. From this diagram, you may notice that steatosis has been mentioned when ALT predominant and mentioned also when AST predominant. That's because in the literature there are different different reports about the situation in fatty liver. It may present by predominant AST or predominant ALT, but alcoholic liver disease almost predominant AST, and viral hepatitis almost predominant ALT. Mild elevation also, we should exclude non-hepatic causes of rising enzymes like hemolysis, myopathy, thyroid disease, strenuous exercise, macro AST. On the other hand, if there is severe elevation in ALT and AST, and by severe elevation we mean more than 15 times the upper limits of normal, this situation has limited causes, so limited differential diagnosis. The causes include drug-induced liver injury by acetaminophen, occupational or environmental toxin like carbon tetrachloride, ischemic hepatitis, acute viral hepatitis A, B, D, E, and herpes. If the rising in the enzymes is intermediate range, this will be less useful for limiting the differential diagnosis most of all hepatocellular disease will be included in your differential diagnosis. For markers of cholestasis or obstruction, if alkaline phosphatase rising is isolated or associated with hyperbilirubinemia in cholestatic disorder, alkaline phosphatase rising may be the sole abnormality in many cholestatic or infiltrative diseases to be interpreted in the clinical setting of history and physical examination if the sole abnormality. Markers of cholestasis also may include gamma GT and bilirubin. Physiologically, increased alkaline phosphatase should not be forgotten. It may increase in tissues undergoing metabolic stimulation like growing bones, in third trimester of pregnancy from the placenta, or in adolescence from growing bones. After exclusion of physiologically raised alkaline phosphatase, we should put in differential diagnosis if there is increased alkaline phosphatase. May be of hepatobiliary origin, like bile duct obstruction, primary biliary cirrhosis, primary sclerosing cholangitis, medications, infiltrating disease, hepatic metastasis. Also increased, but with to less extent in hepatitis, cirrhosis, vanishing bile duct syndromes, and benign recurrent cholestasis. It may also increase from non-hepatic causes like bone disease, pregnancy, chronic renal failure, lymphoma and other malignancies, congestive heart failure, childhood growth infection, and inflammation. Another point that should be in differential diagnosis of raised alkaline phosphatase is infiltrative disease infiltrating the liver tissue, like sarcoidosis, tuberculosis, fungal infection, other granulomatous disease, amyloidosis, lymphoma, metastatic malignancies, and hepatocellular carcinoma. All infiltrating disease that infiltrate the liver can raise the alkaline phosphatase. So, when we are faced by raised the serum alkaline phosphatase, you should repeat the test to confirm. Then, number 2, confirm hepatic origin. This can be confirmed by seeing the serum gamma GT. It will be also raised. 5-nucleotidase will be also raised. Or you can ask if available in the lab which alkaline phosphatase isoenzyme. Is it hepatic or extrahepatic? But usually, if the rise in alkaline phosphatase is not associated with rise in 5-nucleotidase or gamma GT, this is of extrahepatic origin. If these two companions are also raised, this will confirm hepatic origin. Third step, if medications suspected, discontinue them and repeat the test. Again, persistently elevated serum alkaline phosphatase, you should evaluate for cholestatic liver disease, infiltrative liver disease, or biliary obstruction. So, alkaline phosphatase elevation up to 3 times the upper limit of normal, this is non-specific, can occur in all types of liver disorders. If more than 3 times upper limit of normal, you should think in cholestatic disorder, infiltrative disorder, and metastasis. This is an algorithm for a patient with raised alkaline phosphatase. If gamma GT increase is not present, so this is mostly non-hepatic cause. If gamma GT is also increased, so this is mostly hepatic origin. If persistent increase more than 3 months, go for liver ultrasound. Or if the patient is symptomatic, don't wait 3 months and go for liver ultrasound. If alkaline phosphatase is twice the normal, go for liver ultrasound. Don't wait for 3 months. Okay, abdominal image, abdominal ultrasound. If you find a liver mass, so this is a focal lesion in the liver, go for further investigation image. Or this is an infiltrating mass. Or you look to the bile duct. If there is no bile duct dilatation, screen for medical cholestatic condition, like primary biliary cirrhosis, which is now called primary sclerosing primary biliary cholangitis, screen by serum antimitochondrial antibody and consider liver biopsy. If there is biliary dilatation, go for ERCP to release the biliary dilatation. And now to the bilirubin, which is a marker, could be used as a marker of cholestasis and at the same time could be used as a marker of hepatocellular injury according to the situation. As we mentioned before, the liver cell has three functions to do: uptake of bilirubin from the circulation, conjugation of the bilirubin to be water soluble, and excretion through the biliary tree. As we mentioned before, the differential diagnosis is according to the pattern of abnormality. If the change is predominantly in the AST and ALT, denoting hepatocellular pattern, we may put the differential diagnosis: alcohol-related liver disease, viral hepatitis, other infections, NAFLD, hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, autoimmune hepatitis, drugs and toxins, and so on. If predominantly cholestatic or infiltrative pattern, which means that the main increase in alkaline phosphatase plus minus bilirubin, we may think in cholelithiasis, malignancy, primary biliary cirrhosis, primary sclerosing cholangitis, intrahepatic cholestasis of pregnancy, HIV, granulomatous liver disease, drugs and toxins, or non-hepatic source. The third condition to found isolated hyperbilirubinemia. This may be a congenital syndrome like Gilbert syndrome, or may be from red blood cell source from hematoma or hemolysis. Drug history should not be forgotten in both patterns. If we found cholestatic pattern, there are long lists of drugs that can cause cholestatic pattern. On the top of the list, amoxicillin clavulanic acid, augmented, anabolic steroids, chlorambucil, clopidogrel, estrogen, methimazole, tricyclics. All of these can cause cholestatic pattern. Other medications that can cause hepatocellular injury, the prototype is acetaminophen, causing acute liver failure, amiodarone, an antiarrhythmic, carbamazepine, antiepileptic, and so on. So drug history is of utmost vital importance. And now to the last sixth step in our roadmap to perform the diagnosis. Again, we should stress on diagnosis should be put on history, examination, and investigations. You cannot put diagnosis of liver function neglecting the history or examination only on lab results. This is not the proper way, and this is not accepted. In the history, you should stress on risk factors for liver disease, like high-risk behaviors, intravenous drug use in the past or present, multiple sexual partners, high-risk sexual activity, tattoos, non-sterile body piercing, alcohol abuse, commonly implicated medications like acetaminophen, NSAIDs, antibiotics, anticonvulsants, and so on. We should revise for history of systemic illness like diabetes, obesity, hyperlipidemia, iron overload, autoimmune disease, metastatic cancer, inflammatory bowel disease, and others. History of travel to or residence in less developed regions, history of needle-stick injury, receipt of unscreened blood product, history of hemodialysis, contaminated food or water. It may suggest hepatitis A. All of these risk factors should be asked in the history. During examination of the patient, we look to a stigmata of chronic liver disease, a stigmata of hepatocellular decompensation, cirrhosis, or vascular decompensation, portal hypertension. Look to astigmata of accumulation of bile constituents. Jaundice, if bilirubin accumulated, if bile acids accumulate, it will cause pruritus. Lipid accumulation causes xanthomata. If there is copper toxicity, Kaiser Fleischer ring, which is rare. Or we may found in general examination in a case of cholestasis, reduced bile in the intestine causing malabsorption of fat-soluble vitamins, vitamin A, vitamin D, vitamin E, vitamin K, calcium, osteoporosis, osteomalacia, and so on. Investigations. The workup for elevated serum aminotransferase levels according to the history and examination and investigation. We will add specific tests according to the situation, according to rules of three. If suspected viral hepatitis, screen for hepatitis A virus by anti-HEV antibodies, IgM and IgG. Hepatitis B virus, all the markers of hepatitis B virus, hepatitis B is antigen, and so on. And PCR, hepatitis B virus DNA, when available. Screen for HCV by hepatitis C virus antibodies and HCV RNA. This is the three viral screens. Autoimmune screen, ANA, anti-smooth muscle antibodies, asthma, antimitochondrial antibodies. And the metabolic panel, iron profile, if you suspect hemochromatosis, ceruloplasmin, if you suspect Wilson's disease, alpha-1 antitrypsin phenotype, if suspected alpha-1 antitrypsin deficiency. So, can you read this? Okay. I hear somebody said me, others say you. Both are right to conclude interpretation of liver function tests is more than simple reading. You should know the situation behind to give a wise decision and wise logic reading. Thank you very much.